Good afternoon, everyone. My name is Peter Berman. I'm the director of the School of Population and Public Health, and I want to welcome you to our final Voices in Health seminar of this academic year on the disease burden of mental illness and substance use in North America, comparing Canada, the USA, and Mexico. As always, I want to begin by acknowledging that we are privileged to gather on the traditional, ancestral, and unceded Indigenous territories of a number of the First Nations people here in British Columbia, and perhaps from elsewhere if you're not located in British Columbia, including the Musqueam, Squamish, and Tsleil-Waututh First Nations, and we are always grateful for the opportunity to be able to meet here in this beautiful land. Today we're going to speak about an important key issue globally, but also locally, and one that is even relevant as we struggle today in dealing with the current COVID-19 pandemic, perhaps ever more relevant. Our talk will be moderated by Dr. Joseph Puyat, an assistant professor here at SPPH, and I'm going to turn the floor over to him to take us forward. Thank you very much, Joseph.
Thank you, Peter. My name is Joseph Puyat, and I'm an assistant professor here at the School of Population and Public Health. Before I introduce our speaker today, I'd like to quickly review our schedule. So for the first 45 minutes, we will have Dr. Daniel Vigo give his talk, to be followed by our discussant, Dr. Shekhar Saxena, who will be joining us from Geneva, and he will share his reflections on the talk. After that, there will be a question and answer, so we will take questions from the audience. Please note that we will be holding off questions until after the discussant makes his remarks. So I now have the pleasure of introducing our speaker today, who is Dr. Daniel Vigo. After obtaining a bachelor's and master's degree in clinical psychology, and also a medical degree, and a university specialization in psychiatry, our speaker, Dr. Daniel Vigo, worked in clinical research, teaching, and leadership positions across sectors. He developed the very first assertive community treatment department in Argentina in collaboration with Proyecto Suma, King's College in the UK, and Columbia University in the US. He also obtained his doctorate at Harvard, where he focused on studying the burden of disease and service improvement and health systems assessment. Currently, he's an assistant professor at the University of British Columbia, a lecturer at Harvard Medical School, an advisor to the Pan American Health Organization and the World Health Organization, as well as chair of the Health Services Work Group of the WHO World Mental Health Surveys initiatives, among other roles in and organizations of national and global standing. So without further delay, I will hand it off now to Dr. Vigo for his talk, which is entitled The Disease Burden of Mental Illnesses and Substance Use in North America, Comparing Canada, the US, and Mexico. Dr. Vigo?
Thank you very much, Joe. Before I begin, I also want to especially thank Professor Shekhar Saxena for joining us. Shekhar is the former head of WHO Mental Health and Substance Use Unit, and in that leadership position, which he held for a very, very long time, he has inspired many of us into the role we took in terms of both research and our professional practice in the area of global mental health. Shekhar has led a number of initiatives that have taken global mental health to the next level globally. And so it's a pleasure and an honor to have him here, and a guilty pleasure at that, because knowing he's in Geneva at a terrible hour of the night, it makes it even more important. Thank you very much, Shekhar. So I have one question for IT. The screen that I'm sharing now, is the correct one, or should I share a different screen?
Yeah, that looks good, Daniel.
Okay, so is it it doesn't include all the faces of the people that have joined? It's just the presentation?
Yeah, it's just the presentation.
Okay, great. Just one sec. Okay, so first of all, thanks Peter and Joe and Joseph for hosting and moderating, and also Alexandra and Simona for supporting this session. It is an honor for me to join in this Voices in Health series of seminars, and I really look forward to our continuing and increasingly close collaboration between the Department of Psychiatry and the School of Public Health, of Population and Public Health. So today we're going to talk about the disease burden of mental illness and substance use. We're going to go first through an overview of the different frameworks that try to capture this impact of diseases in communities and in different subgroups of the population. And we do a small overview and an explanation of why it is important to be aware of the assumptions and the technical details of these calculations. Then we are going to apply this estimation frameworks to Canada, the US, and Mexico, with a focus on how this burden varies across the lifetime and how it varies between men and women. And then we'll have a brief, or hopefully not so brief, time for discussion. I'm going to rely on Joe to let me know when my time is running out, so that I can leave enough time for discussion. So the first thing we're going to do is discuss what is this concept of disease burden. What does it try to capture, and why is it necessary? And then we're going to see what are the issues that the disease burden framework has for specifically with mental health related burden. So the concept of burden is a very interesting concept, and I became aware of it and interested in it very early in my career. I was doing an internship in psychiatry at McLean Hospital, and working on my first paper with Ross Pildeserini, who, for those who are not physicians, is the guy who basically wrote the chapter on psychopharmacology on the Goodman and Gilman book. So it's someone that we have all admired, and we were writing a piece on the systematic review on the use of anticonvulsants for major depressive disorder, and I was in charge of putting together the introduction. And I immediately came across the concept of the burden of major depressive disorder, and I was very intrigued by the concept, by this composite measure, let's say the components of which are not always well understood, and certainly not by me at that time, but it was the framework that put really mental health into the map in the early 90s through a World Bank commissioned report, and through the work of Chris Murray and Alan Lopez, and again there the Harvard School of Public Health and WHO working together to provide the technical tools that the World Bank needed for its first report on health. So a really groundbreaking endeavor. And I was intrigued and interested because of the concept of burden evokes a lot of complex concepts, and we're going to start with a bit of dictionary definitions of it. The burden is something that is carried, and this is the American Heritage Dictionary, which has a lot of etymological and historical references. Something that is carried, and we see there what appears when we Google burden and beast of burden, and clearly examples how or shows how the burden can sometimes be paralyzing. There's also something that is emotionally difficult to bear. And in this case, Atlas carrying the weight of the world and of heavens, by the way, as a punishment. And finally, there's a relationship, or at least in this dictionary, with the economic burden. It's a source of great worry or stress. There's a weight that is carried. And the example they put is the burden of economic sacrifice rests on the workers. And this evoked this beautiful sculpture that I've seen since I was very, very young in Argentina, in Buenos Aires. And I was always intrigued why this sculpture was called something along the lines of hymn or chant to labor, or to work. And so in this version of work, a bunch of people of all sexes and ages are carrying a rock with no clear purpose. And finally, the last definition of burden in this dictionary is the amount of disease-causing entity present in an organism. And here we're getting closer to what Murray and Lopez initially wanted to represent by creating the DALIs. In this case, this comes from veterinary medicine, where the number of parasites in an animal give an idea of what the level of impact on the health of that animal will be. So after all of these introduction, why do we care about burden? Why do we actually need a composite measure that has so many assumptions built into it that sometimes makes us pause in terms of the actual meaning and impact that it has? Well, we need something that allows us to estimate and compare the overall disease impact on communities. We need something that allows us to compare across diseases and across population subgroups. And for reasons that we will see, we cannot do that with the more traditional measures like prevalence or mortality, etc. So how do we compare the impact of, for example, schizophrenia in a very low resource setting? For example, this is a quote-unquote healing center in Ghana with treating again quote-unquote people with schizophrenia. How do we compare the burden of schizophrenia with the burden of opioid use disorder, such as, for example, in the downtown east side, where in a high income setting such as ours, and successfully or not, there's a sort of whole of society effort to try to diminish that burden. And how do you compare those with, let's say, this disorder that produces a mild impact on the upper respiratory tract of this child, with this other impact, which can be caused by the same disorder if we were talking about COVID-19, but in a different age group and at a different level of severity. So basically, there are two essential components of the impact of disease. One is mortality and the other one is morbidity. And we can capture mortality through different measures, single outcomes, such as life expectancy or all-cause mortality. And then we can also look at cause-specific mortality, right? We can see how many people die from a specific cause in a given period or in a given place and time. And for morbidity, we can look at the number of people that are affected, either de novo with incidence or during a period through prevalence. And then we can also look at the impact through quality of life, functionality, or disability estimates. Now, the question is, how do we combine all of these? And now we're going to go into what are called health-adjusted life years, which are overall composite measures that try to capture all of this, because there are issues with mortality rates and with prevalence and incidence rates. Now, for example, in the case of mortality, from a societal perspective, it is difficult to think that deaths at all ages can be considered equal. Just as a thought exercise, imagine if COVID-19, instead of having a predilection for older adults and being particularly lethal for older adults, it was an infectious disease that targeted infants or very young children. And we've had such pandemics in the past, and we may have them in the future. So the impact of both disorders in terms of burden, disease burden at the community level, would be different. The same thing with prevalence and incidence. Head counts of people with disorders don't capture the morbidity because, as we said, the common cold, COVID-19, opioid use disorder, and schizophrenia are not represented just by the number of people they affect, because the severity varies across disorders and ages. And so the question becomes, how can we weigh this morbidity? Well, the response has been, and there's very many decades have seen different measures developed. These are called collectively health-adjusted life years and are basically summary measures of mortality and morbidity. Now, they come in two flavors. Some of them are health expectancy measures. Basically, they are things that we want to gain, we want to have more of, and the quality-adjusted life years is an example. And then health gap measures. Those are the disability-adjusted life years, the DALYs. And we're going to focus on the DALYs for this presentation, but I think it is important to start understanding that when we choose an avenue, we start narrowing our ability to see things. We start narrowing our ability to understand things. And unless we're very aware of the impact of our assumptions, then we may just be doing a disservice to the field we are studying. So the QALYs are a summary assessment of the quality of life related to general health states, not disorder-specific health states, between 0 to 1, representing death to perfect health. And by summing the number of years in each health state, you can have an idea of the overall QALYs that can be. Basically, this is the traditional estimation. Now, reallocating neurological disorders, we can see how mental health related burden increases its relevance. Reallocating suicide and self-harm, we see how it increases its relevance and nears the top. And including an estimation for chronic pain syndromes, we see how it basically, at the global level, is tied with cardiovascular disease in terms of the percentage of total DALYs directly caused by mental disorders, or rather the mental health related burden. So we're now going to apply this framework to Canada, the US, and Mexico. Now, what is the context in which we are doing this? A couple of years ago, StatsCan, or Statistics Canada, highlighted that life expectancy has stopped increasing in Mexico, in Canada. So we can see here in this graph how after 2016 and 2017, this line is flat. And this was the first time that both for males and females, life expectancy had stalled in 4 decades. This was largely attributable to the opioid crisis, and largely attributed to British Columbia, and largely attributable to young men, as we can see here too, whereas most other groups are increasing their life expectancy, the young men are decreasing. In the US, a similar process, increasing longevity for decades, but then in 2014, a little bit before Canada, there was a reversal in this trend with declines in life expectancy at birth. And some researchers, particularly Case and Deaton, in 2015 highlighted, and by the way, Deaton received a Nobel Prize, if I'm not mistaken, that year or the year before, highlighted that these deaths were due to what they called deaths of despair, suicide, drug overdoses, and alcoholic liver disease. And this is, in 2017, for example, 160,000 deaths in the US. So more even than COVID-19 in a year. Of course, probably COVID-19 will surpass that, but really a really significant chunk of the mortality was due to this clearly mental health related burden. And by the way, this was driven in Case and Deaton's analysis, though there's some disputes about this, but driven by white males with high school education or less, between 45 and 54 years of age. And we can see here a chart that they developed, shows many interesting things. First, to start with, the inequalities, because Black people had a very high mortality rates, but we can see here how white people, with white males with age 50 to 54 with high school education or less are increasing in their death rate and overall too. So what is happening here? This is in some sense what we're going to try to look at with a reanalysis of the burden in Canada, the US, and Mexico. So we extracted disaggregated sex and age specific country level data for all disorders and countries, and these 3 countries. And we re-estimated the mental health related burden to include self-harm and suicide, alcohol use disorder, and their somatic consequences, because by the way, as you saw, many of these deaths were due to liver cirrhosis or alcohol-related liver disease, and this is not captured. Well, none of these are captured in the traditional global burden of disease estimations. Suicide, alcohol use, drug use, neurocognitive disorders, headache disorders, and epilepsy, plus an estimation for somatic symptom disorder with prominent pain. So this is a tree map that shows in blue the non-communicable disorders. You have dark blue and light blue. Light blue are is the mental health related burden, and in dark blue you can see the rest of the non-communicable diseases. So around 88% of the overall burden. This tree map reflects 100% of the disease burden in Canada. As I said, non-communicable disorders in blue, injuries in green, and communicable and maternal in red. So clearly, mental and neurological substance use disorders and suicide account for almost 1/4 of the total disease burden in Canada. Similar picture in the United States, marginally less, and a slightly different picture in Mexico. We can see that in Mexico, which is typical of developing countries, we have a larger proportion of the disease burden caused by communicable maternal and child disorders and injuries. But still, around 72% of the overall burden in Mexico is caused by non-communicable disorders, 17% of which is caused by mental health related burden. Now we're going to go to the level 2 groupings. The level 2 groupings are within those large groups that we saw, the non-communicable, communicable, and injuries. We're going to look at how the mental health burden compares to other groups such as cardiovascular disease, cancers, etc. So the mental health related burden is the largest relative cause of DALYs of all NCD groups by far, followed by cancers in Canada, cardiovascular disorders in the US, diabetes plus kidney disease in Mexico. And in Canada and in the US, the mental health related burden is actually between 1/3 and half of the total disease burden, including injuries, including maternal and child and infectious disorders between 10 and 50 years of age. And it's even more than half the total burden of disease in the prime of youth, let's say at 25 years of age. In Mexico, similar picture, but slightly lower. The mental health related burden is between 1/5 and 1/3 of the total burden between 10 and 50 years of age. So now we're going to see this with a life course perspective. We're going to use stacked area charts to see how this burden evolves throughout the lifetime. So what you're seeing here is on the x-axis, 5-year-old groupings, and then on the y-axis, the percentage of the total burden. This rectangle contains the whole disease burden in Canada by age group. And basically what we can see is that in blue here, all the blue ones, by the way, all the different shades of blue represent all the non-communicable disorders. And then we have injuries in green and infectious plus maternal and child disorders in red. But we can see that around 15 years of age in Canada, more than 50% of the total disease burden is mental health related. Then it stays around 50% for decades. And it's only crowded out, as we said before, when cancers take a protagonism or preponderance here around 65, 70 years old. In the United States, we see a similar picture, a little bit more injuries, but nevertheless, about half the burden for decades during youth, and then crowded out by cardiovascular disease as people age. In Mexico, it is slightly different. We can see the dramatic impact of injuries. This is violence in Mexico, but nevertheless, about a third of the total disease burden is due to mental health-related disorders between, let's say, 15 years old onwards, and it is displaced by diabetes and kidney disease that increase during adulthood. So what we're going to do now is focus on the mental health related burden. So we're going to look at 100% of the mental health related burden in each country. So first we're going to see that until 4 years of age, the mental health related burden is due to autism spectrum disorders and epilepsy. Autism more prevalent and more impactful in the US and Canada, and epilepsy in Mexico. Then during late childhood and early adolescent, conduct anxiety disorders and headache disorders constitute more than half the burden. And then we see a stable pattern throughout adulthood that has common mental disorders being the more impactful disorders, and we'll see the details of this in the coming slides. But then we see that the substance use disorders are also very impactful, headache disorders, and then severe mental disorders. And
this is Joseph, just to let you know, you have 9 minutes.
Thank you so much. So this is what we were discussing. In blue, we have here the different shades of blue show the common mental disorders. This is depression, anxiety, suicide and self-harm, painful somatic syndromes. So almost 50% of the burden, rapidly around 15 years old, is due to these disorders, and then stays like that for most of adulthood, and is then, then neurocognitive disorders, which is this green area here, takes the protagonism. Here we can see in brown substance use disorders. This lighter brown is the impact of the drug use disorders, mostly the opioid use epidemic. We also see the importance of headache disorders, for example, in Canada. The picture in the United States is similar, but with a much more impactful even a burden of drug use disorders and particularly opioid use disorders, which leads to almost 12%, for example, of the total burden, including all non-communicable or infectious diseases, all maternal and child health disorders, around 25 years old, to be due to the opioid use disorder burden. In Mexico, we see a slightly different picture, and we can see many, many interesting things here, right? There's the increase in anxiety-related disorders during late childhood and early teenage years. We can see how here, for example, the conduct disorders are very relevant during the late childhood, and so on and so forth. And this will help us target our interventions to address what are the most relevant burdens at each moment or at each age group. Oh, sorry. So, and finally, Mexico, it is different, similar but different, because as we see here, epilepsy is much more relevant than autism in the early years. We can see that suicide and self-harm is much more relevant also during late teenage years and early adulthood. And we can see that drug use is not such a big problem in Mexico as compared to alcohol, which in the darker brown here is the bulk of the burden for people between let's say 29 and almost 65 or 70 years old. So in absolute terms, because we have been looking at relative terms, meaning the burden as a proportion or as a percentage of overall burden. Now we're going to briefly look at the absolute burden of disorders. And there is a gradient in absolute terms, of course, adjusting for population size across the three countries, with Mexico having the lowest disease burden attributable to mental disorders, Canada in an intermediate position, and US having a much larger mental health related burden. And by the way, this is the uncertainty intervals for these estimations do not overlap. So this gradient is actually a very, I find, robust result. What we're going to focus on now is the difference between men and women in terms of the mental health burden. Unfortunately, we don't have data on gender, so we are stuck with men and women as sex related categories, and we miss the important issue of how the burden varies in terms of gender and more diverse populations. So by sex, in Mexico and the US, the burden on men may be larger than that of women. And as you can see, or we will see in the next slide, the burden of men is much lower in Mexico than in the US, 4,600 versus 7,000, but much larger than in women in each of those countries, which is 4,001 and 6,555 Jalis per 100,000. In Canada, interestingly, it's different, and the burden on women of mental health related conditions may be larger. The reason that this is not so robust is that the uncertainty intervals overlap. Now, in the case of the disease burden by sex, this is in the US, men, more than half of the burden of the DALYs in the United States, adjusted for population size, are due to drug use disorders, suicide, and alcohol use disorders. And in women, drug use disorders, headache disorders, and depressive disorders. In the case of Canada, oh no, sorry, this is the same, this is the United States. You can see here all of the disorders listed in order of how burdensome they are. And you can see that more than 50 is because of these three, and these three in the United States. And we can come back to this table if it comes up in the discussion. So in the case of Canada, the burden is less concentrated. So more than half the burden in men is due to drug use disorders, suicide, painful somatic syndromes, alcohol use disorders, whereas in women, headache disorders, depressive disorders, painful somatic syndromes, and drug use disorders cause almost 60% of the burden. We can see that again here. 4 disorders in each of the sexes capture more than 50% of the total burden for each group. And then we have all of the disorders ordered by rank. Finally, in Mexico, Again, the disorders are less concentrated. More than half the burden in men is due to alcohol, suicide, headache disorders, and major neurocognitive disorders. And in women, headache disorders, depressive disorders, major neurocognitive disorders, and anxiety disorders. So needless to say, as you can see through these tables and this slides, we would see none of this in a traditional GBD approach, because you wouldn't see any of the to mental disorder burden, because you wouldn't see all of the, of course, the headaches and major neurocognitive disorders, the substance use disorders, or the suicides of this world. You only capture the depression and anxiety. Again, similar thing here, we can see the ranking, and then we can come back if this is of interest in the discussion. So just to wrap up, the burden of disease frameworks are built on a lot of assumptions. All of these assumptions have consequences. The main one is that the disease burden is restricted to, of course, the impact on life expectancy, but also that within the skin functioning. That means that it's a combination of death and the impact on bodily functions, senses, cognition, and ambulation. But it does not include societal burden, economic burden, family burden, decreased or perturbed social interactions, or decreased quality of life. So it's a very narrow approach to the burden that disorders have. DALYs in general, as we said, are weighted by, YLLs are weighted by a standard life table. And what that means is that it is not weighted by local life tables, but by what is the maximum life expectancy that any group of 5 years has in any country or territory of more than 5 million people. So it's a bit of a chimeric table that tries to capture what would life expectancy look like if there weren't any other social determinants of health leading to earlier deaths. So in fact, we're using, for example, the life expectancy of Japan versus the life expectancy of the Central African Republic to estimate the DALYs in the Central African Republic. And that has a lot of implications that we can discuss in the Q&A. And then the disability weights, again, they reflect value judgments of the general population on what each health state is. It does not reflect the any objective assessment of the burden or the disability by people who have the disorder or by experts. It's just value judgments by the general population. And the severity distributions are not country specific. They are based on functionality surveys in high income countries. And this brings up a bunch of questions that we will bring up hopefully in the Q&A. This type of approach in particular misrepresents the burden related to mental health because there are no YLLs there. There's just a fraction of the YLDs because they don't include some of the most prevalent disorders. And again, as a final slide, it is important and necessary to use these composite measures, but we need to know how the sausage is made, because otherwise we're just repeating assessments that are potentially problematic because of their ethical consequences, allocative implications, and ethical implications. And also because they are, in fact, biased unless they are corrected. So the acknowledgements, this work was done, co-authored by myself and Laura Jones and Graham Thornycroft and Rifat Atun. It wouldn't have been possible, needless to say, without the work of WHO and the Institute of Health Metrics and Evaluation that makes all of these studies available for everyone to access. So this is just some references. Okay, sorry, I may have run a little bit over and I may have rushed through some of that. I'm sorry for the technical difficulties, but hopefully we have time for a bit of a discussion.
Thank you very much, Dr. Vigo, for your very interesting talk. We will now hand it off to Dr. Shekhar Saxena. As Dr. Vigo said earlier, Dr. Saxena is a professor of practice of global mental health at the Department of Global Health and the Population at the Harvard Chan School of Public Health. He's a psychiatrist by training. He has served in the World Health Organization since 1998, and he will briefly introduce his work and spend a few minutes responding to the talk. And after Dr. Saxena's talk, I will take questions from the audience. So please raise your hand by pointing your cursor at the bottom of your screen and looking at the and clicking on the section that says participants. Or you can also use the chat function of the Zoom platform. Dr. Saxena?
Thank you very much, Joe. Thank you, Peter, for inviting me to join this session. Thank you, Joe, for introducing me. And thank you so much, Daniel, for making an excellent presentation of some of the excellent work that you and your colleagues have done. I will essentially make 4 points quite briefly and will be available for any further discussion. The first point is the value and the benefit of combining the mental, neurological, developmental, substance use disorders and suicide as a condition. And Daniel already referred to some of the work that was done by WHO as a part of the MHGAP project, which includes all of these. And also I would like to refer to the ICD-10 as well as the ICD-11. I was fortunate enough to be involved in the MHGAP work, but also in the ICD revision. And the message is very clear that all of these disorders and conditions need to be put together. There are many reasons for doing that. The reasons are public health oriented, but also clinically oriented. For example, for the public health purposes, for a lot of planning at the government level as well as at the health system level, the kind of people who provide help for these conditions are exactly the same. And in many cases, there are many comorbidities. So from a public health viewpoint, it makes sense to look at them together. And also in most of the low and middle income countries, and we just saw some figures from Mexico, the infrastructure for care is actually together for all of these conditions, although in some high income countries, there is a clear dissociation for the care pattern of these disorders. But from WHO viewpoint, as well as from the global viewpoint, it just makes sense to combine them. And any tendencies which we do see now, even within the GBD exercise, to separate them out, not to aggregate them, actually creates more confusion and less coherence. So that's the first point I wanted to make, that we should definitely look at them together with a qualification that not all suicidal deaths are associated with mental disorders, but they're certainly connected to mental health of people. So it again makes sense for that to be combined. The second point I want to make is on the limitations of the GBD exercise. And Daniel has talked about it in quite some detail. And I would just like to say that those limitations are obvious, but in many other areas also, but they are of particular problem for mental health and substance abuse issues, because they exclude the deaths, as Daniel said, but also the suicidal deaths more specifically. And these are very big factors. So although these limitations could be important for other health conditions, but they're extremely important for mental health and substance use conditions. So there is absolutely a need for taking care of these limitations. But I also want to make a related point that the GBD methodology has evolved over a period of time. I was actually professionally active and in WHO when this whole exercise began. And I remember some of the collaborators, including Chris Murray and Alan Lopez, sitting together in WHO and doing some of these calculations way back in 90s. And I must say that the transparency has increased, but it needs to increase much more. GBD should not be a black box. It should be an open source initiative where other people could examine the data like Daniel has done, but also suggest ways in which it should be, it could be analyzed in alternate ways for different purposes. And there, even more open source setup is necessary. And I think we have to go much further to achieve that so that it can truly become a collaborative and as well as a useful exercise. The third point I want to make is to highlight some of the findings that Daniel had just now presented. But there are many, many findings. Obviously, quite a few of them will be interesting for researchers. And some of you might be very interested in some of these very specific findings. But from a policy perspective, one must highlight the biggest findings, the ones that have the most policy implications. And there I would like to identify 3 findings. One is that 1/4 of the total burden is because of these conditions. Mexico is an exception, but it is true for many other countries besides the US and Canada that he talked about. And that's the finding which is eye-opening. It must be highlighted in big, bold letters, together with the other finding that 1/3 of the disability adjusted life years or years of life lived with disability are because of these conditions, which is enormous. And that must be highlighted very clearly to the policymakers. But one other finding which I was very struck by in this paper is that 50% of the burden amongst young people is because of these conditions. And that's a finding that has not been highlighted very much in the literature, and there is scope for doing that. And if these 3 are highlighted to policymakers, I think it will make a lot of impact. So my final point is about how to convey these findings to policymakers. It is good to analyze these data. It's good to publish them in a reputed scientific journal, but it's much more important to really present it to the policymakers and policy advisors in a way that it can really make a difference. And their scientific papers only go that much. It has to be policy briefs. It has to be social media presence. It has to be certain nuggets of information which are presented to them in a variety of ways. It could be also a small video actually that could be produced, which will certainly have a lot of dissemination power. And also highlighting it through the lay media, the journalists, interviews and other things. And all of these need to be tried because having the research, having the data is important, but having that to make an impact is much more important. So I hope and wish that Daniel and his colleagues are doing that, not only presenting that in seminars like this, but actually putting it in front of the people who sometimes make these big decisions and making sure that they understand this in a language that they understand better, and also to advocate for this, which I always call evidence-based advocacy, which these data will go a long way in doing that if presented in a way that they could understand, together with the presentation of these findings to developmental agencies, to philanthropic foundations, and also in general to civil society, which might really take these findings and use them in a variety of ways. Last point for this dissemination exercise, the World Mental Health Day, which is always observed on 10th of October, this year will have the theme of access and investments. And some of the findings that Daniel has presented make a lot of sense for increasing the investments. And so that will be one occasion in October to really have these findings presented to the world in a way that they could make a difference, not only in these 3 countries, but all over the world. Thank you very much for giving me a chance to talk about this.
Thank you very much, Dr. Saxena, for sharing your reflections with us. We will now open the floor for questions. We'll start off with any questions from the group. Then I can read the questions that were sent by the chat function. Maybe I could ask a question first, if you don't mind, Dan. It's something that I was thinking as you were presenting your slides. I was wondering when the first global burden of disease study was released in the 1990s, they were saying the mental health is the 4th cause of disability worldwide. And then a few years ago, it became number 2, and then now it's referred to as being the number 1. I was just wondering how much of that change in the ranking is due to our improved understanding of of how to actually estimate the burden of disease.
Well, so what I would say is that what has happened now is that these reinterpretations or reformulations of the GBD data have had more dissemination than the official estimations, because the official estimations have not actually increased but decreased, as I showed some of from the 2016 calculations, where it was back to 5th, and now, as Shekhar said, they are presenting mental disorders and substance use disorders separately, so the mental disorders will go further down. So, but what has happened is that WHO, disease control priorities, or other groups of researchers are choosing to present different aggregations than the ones that are put out by the let's say official GBD calculations. But again, as I said, the official ones have not increased. In fact, they have decreased, if anything, to the extent that, for example, the most impactful disorder in terms of disability-adjusted life years are sometimes, in some calculations, the musculoskeletal disorders, which of course have included in them the mental health related chronic pain syndromes that are legitimate mental disorders, but that are not captured in the GBD framework as such, but are captured within the musculoskeletal quote unquote disorders. And if we have evidence of anything, it is that those disorders are not caused by the let's say joints or muscles or any other of those causal pathogenic pathways. So I guess the answer to that is that the field has become more aware of the need to interpret these assessments carefully. For example, Shekhar mentioned the importance of sharing these types of findings with decision makers or with multilateral organizations, which is something that we have continued to do since the first publication of the new framework. And for example, PAHO, the Pan American Health Organization, the report on burden of disease on the Americas, which was released a couple of years ago, is based on this framework. And now we've also developed a disease burden analysis by country in the Americas for PAHO, that again is to be published at some point. And so this is reaching also decision makers at the country level through WHO's regional offices and connections with decision makers. So what I would say is that there's a number of circumstances that are improving our understanding of the relevance of the mental health related burden.
Joe, if I can just add a footnote to
Yes,
what
please.
Daniel said, also that the burden figures are always a proportion of the total burden. So in many countries, some of the other sources of burden are going down, for example, the infectious diseases. And so proportionately, the non-communicable disease burden, including of mental and other disorders, will actually go up proportionately, even if the actual numbers don't go up. So there will be that kind of adjustments that are there over a period of time, because the disease profile changes along with the time and along with the demographic patterns in a country, which also evolve over a period of time.
So we're making progress on other areas, but not so much on mental health. That's why it's slightly increasing in rank.
Also because the populations are aging, and we do know that at least neurological conditions are more common during the older age groups. So there will be an expected increase in the burden as the demographic pattern changes.
Thank you. Questions from the audience? I have another one that I received from the chat. This one is directed to you, Dan. Can you highlight what, in your view, are the most policy relevant differences between your estimates of burden and those of the GPD? And what would be the policy response implied by such differences?
That's a very good question, and it points to something that also Shekhar mentioned, which is that in any rational health system, you would deploy the health system's resources to tackle the most impactful disorders at the primary care level. And so, for example, what these estimates show is that the primary care physicians or the primary care nurses, or whoever is delivering primary care, should have a clear idea of which are the most impactful disorders. And of course, amongst them are some of the common mental disorders that are not usually the focus of attention, such as self-harm and suicide, such as painful somatic syndromes, such as headache disorders. None of these is in the radar of many, let's say, primary care settings at the different age groups, right? And needless to say, the importance of the major neurocognitive disorders as population ages. So I think the most impactful consequence would be the need to rethink what are the areas of focus. This is different in a different level of income. In developing countries, what we find is that many times the health system is more prepared to deal with maternal and child health concerns and communicable diseases, which is completely understandable. But as the burden switches from those disorders to non-communicable disorders, the health systems need to adapt and also deploy services and resources for these burdensome disorders that, for example, constitute more than 50% of the burden of the total burden in youth in industrialized countries. And I'm not sure if GPs, for example, here in Canada, have such a clear idea of what that the 50% of the burden that they're dealing with in youth is mental health related. I don't think so. I think they're much more focused on other issues, and there's a certain shift that needs to operate at any level of income. But there's I think a message there of the need to redeploy our primary care resources to address this, because this is the most burdensome group of disorders any group of disorders in Canada and in most places.
I imagine you're observing the developments in this area, and you were saying that from your impression, our primary care system here hasn't exhibited that shift. From your observations in other parts of the world, were there any country that's on the top of your mind right now that seems to be paying attention to this improved understanding of the burden of disease for mental health and substance use?
Yes. So, well, Canada is supposed to have universal health coverage. However, the last time I checked, and this may be a couple of years from now, so this may have changed, but 30% of expenditures are actually private expenditures. So it's not a single payer system, in fact. And that 30% is largely driven to a very important fraction by spending on psychotherapy, by spending on long-term rehabilitation of many of these mental health related conditions, meaning by it's driven by unmet need in terms of universal health coverage inclusive of mental health. Other countries, for example, in the UK, but there are others, the imbalance between the expenditures on mental health and the burden on mental health is lower. In Canada, the imbalance between the expenditures and the imbalance between the burden attributable to mental health and the efficiently allocated expenditures is 3. So the burden is 3 times the efficiently allocated spending as a proportion of either total health burden or total health spending. In Canada, 3. In the UK, for example, is, if I remember correctly, 1.5 or 1.8. So there's a larger proportion of the efficiently allocated spending that's going towards those expenditures. In general, the more comprehensive coverage that systems provide, the more truly single payer the system is, and the more integrated they are, the larger the fraction they allocate to mental health. And then again, some other countries have started to implement, low income and developing countries have started to implement mental health gap approaches. So meaning manualized approach to scaling up mental health services through primary care in several continents. And again, it's a difficult process and it's a work in progress, but it is improving without a doubt. The fraction of spending allocated to mental health tends to increase. I don't know what's going to happen after COVID, but this is, no one knows, but let's say before COVID, it was increasing, and the fraction of that was allocated to psychiatric hospitals was decreasing. What that means is that the allocation of funds was improving, because the allocation of funds for mental health should not prioritize psychiatric hospitals, should prioritize the community services. And we've seen that in the, that's one of the big, I would say, big applications of this type of studies. As you could see, the burden in any of these 3 countries, the burden of the common mental disorders, the blue stacked areas, reach nearly half of the total mental health burden. Several times the burden of severe disorders at the population level. So it doesn't make any sense to allocate 100% or 80% of the funds to distributed neuropsychiatric hospitals, right? That only treat tertiary hospitals, that treat the most severely affected. Those more severely affected could be treated in the community with very small exceptions.
Thank you. Any other questions from our audience?
I see a hand raised there.
Oh yeah, Imene?
I would like to ask a question related to what you just said about the UK, and then earlier there was the policy. So UK definitely does not have a single payer system. They do have a large private system that complements and supplements what the public system covers. And so I'm really surprised with the 1.5 to 1.8 ratio that you cited. So my question would be, what are the, well, the first question is it because they actually have a fairly distinct part of their public system that's called social care, and that might have a different ratio between private and public. So it's health and social care in the UK with a two-tier system. And where are the policy levers that the UK system is using to look so good in their more equitable distribution of funding?
So even though there is a private sector, it doesn't reach the 30% that it does reach in Canada. So again, the last time I checked, it was in the single digits. So it's a different size. And again, there may be I stand to be corrected if this is not the case. But my understanding is that the fraction of the spending that is out of private funds is much smaller. That would be my response to that than in Canada.
Yes, I'm sure when you verified that was, you have the right statistics, but as things change by quite quickly with the provincial and federal levels, and depending the federal direction at the time the statistics were issued, and the combination of provincial governments, that 3-to-1 ratio or the 30% to me seems to be. But I realize there's a lot of insured public services over time, at least in the last 5 to 10 years, that have reverted or been pulled out of the public pocket. And so obviously mental health has suffered quite a bit there. Sometimes pediatric services have been in and out of different government plans. So you're correct, probably in the 30% citation, but I think that probably is a fluid figure that changes over time.
So one comment is there's more detail about this issue of the imbalance in a paper that I think it was a 2019 Lancet Public Health paper that has all the details about where the 1.8 versus 3 comes from, and I'd be happy to continue because these things, as you say, are very fluid, and that may have changed.
Mm-hmm. Thank you.
Thank you.
Before I hand it over to Peter again, I was wondering if you have last few things that you wanted to say, Dr. Saxena and Dr. Vigo.
Thank you very much, Joe. The only thing I want to add based on the discussion here is that it's not only how much money is being spent, but also how it is being utilized. And in that respect, many of the low and middle income countries are actually doing a better job than many of the high income countries. And so examples of Ethiopia, Sri Lanka, and many other countries can actually have some lessons for the high income countries too. And when it comes to mental health, we actually have all the countries that are developing country in some sense or the other. So I think there should be a two-directional learning process here, and many of the experiences and experiments in low and middle income countries could actually be worth looking at, even for countries like Canada and USA, and of course Mexico. Thank you.
So just briefly, I completely agree that there's the saying that we're all developing countries in terms of our mental health services. We can certainly see that, particularly with the most burdensome of all disorders here in Canada and the US, which are opioid use disorders, and how. So that I would say is the other very relevant finding, which is that if Canada doesn't want to follow on the steps of the US, there needs to be increased efforts to provide an even more effective set of options for treatment for opioid use disorders. We know that the engagement of users in our forms of treatment is subpar. We know that it's even getting much worse now with the COVID in the COVID context. So I guess what I would say is that it's definitely not a resolved issue. Now, what I would think would be an interesting task for us here at UBC, Peter, and all of us interested in this, is how do we pick up on Checker's suggestion of producing materials that are targeted to policymakers and decision makers who we know are extremely receptive and want to work with us, meaning academics who value very highly the interaction with decision makers. What kind of product could we put together? That could be a collective effort of the School of Public Health, Population and Public Health, the Department of Psychiatry, etc., targeting decision makers in particular.
Back to Peter.
Okay, thank you, Joseph. Well, thank you very much, Daniel, and an especially warm thanks to Shekhar, who has demonstrated to us that he can be extremely lucid and provide a lot of critical input even at an totally unreasonable hour. So I only worry with trepidation how strong his views are at the normal hour. So, and thank you really, Shekhar, an exceptional contribution from your side, and we really do appreciate it very much. And Daniel, for very excellent presentation and comments that are very relevant to us today in British Columbia, and I think we should take up your last suggestions. I know that the BC CDC does produce the portrait of the health needs of citizens of British Columbia, and perhaps we should take a look at that given the importance that is given to mental health issues. We look forward to more collaboration in the coming year. Thanks to Joseph for able chairing of our session, our team, Stefan, Kevin, Simona, Alexandra, for helping us. This is the last Voices in Health session for this academic year. We will be picking up again in September. And I would like to just say that one of the unanticipated, there are very few positives around the COVID pandemic, but one of the positives is that it enables us to bring in a very interesting group of speakers at both an increase to their convenience. They don't have to spend several days traveling back and forth, and also expands the scope of what we can bring in to expand our learning at SPPH and here at UBC. So especially again, Shekhar, thanks for your ability to join us at this time. So be well, everyone, stay well. It's a beautiful sunny day here in Vancouver, and it's already late in the afternoon, so not a bad time to take a walk if you're inclined to do so, and get outside, and we look forward to seeing you again in September. Thank you very much.
Thank you.